It is just a huge, huge honor for me today to be podcast interviewing an orthodontist down under, Dr. Vandana, Katyal. And you're in Sydney, or are you in Sydney, Australia?
Yes.
Where my brother moved there 2 years ago. We were all born and raised in Kansas, and he was the IT director at KU, and he took a job in Sydney and thought they were just going to do something different for a couple of years, and now he has no way he's going to come back. You can't go back from Sydney to Kansas. I've gone down there and visited him a few times and taken a couple of my boys with me, and it's the only place. I've lectured down there about 5 or 6 times, and it's the only city in the world where when you get on the airplane to come back home, you think, why am I going back to Phoenix? It's just a perfect society. So let me read your bio. Having graduated from the University of Sydney with a bachelor's of dental degree in 2001, Dr. Katyal entered private general dental practice and also completed a Master of Science in Medicine Clinical Epidemiology from the University of Sydney. In 2013, Dr. Katyal attended the degree of Doctor of Clinical Dentistry and Orthodontics from the University of Adelaide, as well as membership in orthodontics from the Royal Australian College of Dental Surgeons and Royal College of Surgeons, Edinburgh. Her research interests are in the field of pediatric sleep-disordered breathing, snoring, and oral appliances, which has been published in both Australian and American orthodontic journals. She has also been awarded the prestigious Sam Bulkley AB Orthodontics Traveling Fellowship to continue her research in Germany in the area of miniscrew-assisted rapid maxillary expansion in children and adults. She is also actively involved in setting up a multidisciplinary pediatric sleep clinic at Westmead Children's Hospital. She has been an invited lecturer for major Australian orthodontic and international conferences, as well as sleep medicine conferences. Recently, her research was featured on Channel 9 National News, ABC Radio, 4BC Radio, the Daily Telegraph, the Sun Herald, as well as Bite Dental Magazine.
Yes.
Currently, she is the head orthodontist at CCC Smiles in Mosman, Sydney, and also the lead lecturer for BOSS-Best Orthodontic Seminars and Sessions in Australia. Her treatment philosophy is to practice in an evidence-based manner, and she enjoys meeting new people from all walks of life. She lives by the motto, coming together is the beginning, keeping together is progress, working together is success. She's Australian Orthodontic Board certified, clinical case awards, and 2 traveling research scholarships by Australian Society of Orthodontists, keynote lecture at Indian Orthodontic Society meeting in 2015, and best presentation awards in various conferences globally. Member multiple major orthodontic and dental associations globally. Current career focus, CCC Smiles, clinical practice, BOSS education and seminars for the dental and orthodontic industry, and research publications self-funded since 2016. Author of upcoming book for increasing public awareness titled Love is All You Need and a Good Orthodontist. My God, how did I get you on my show?
In between 3 countries.
My gosh, man, what an exciting career. I want to start with this. I'm 53, and I graduated in 87, so 29 years. And it seems like 5 years ago, you never really heard any sleep apnea. I mean, it wasn't even really a concept. And now it's just everywhere. Arianna Huffington is one of the most famous women in the world. I think she's one of the 50 richest women in the world. She just wrote a book on it. Do you agree that this kind of just exploded on the scene in the last 5 years?
Yes. A lot of it by, unfortunately, people who are not evidence-based, and they are just flogging it. You know, everyone now suddenly has snoring and sleep apnea and need to see an ENT. There's proponents of this type of propaganda. But, it's not a new thing. It's been around since 1800s. It's been noticed as far back as that. And I just think that we're just... everybody's being labeled. Every office I walk into, every dentist, they call themselves sleep dentists now, and it's great that we're all aware. I think we carry this a little bit further. We get really involved in these treatments, and we really sometimes don't know what we're doing and what the evidence is.
Huh. So, and you're even more rare. You're like a tooth fairy riding a unicorn, because you're focused on pediatric sleep apnea and snoring. You're the first person I ever heard that talked about it as a child. But I was at a friend's house a couple months ago, and it was little little what's Jason's boy's name? Jaden. And he
Yeah.
was taking a nap on the couch, and he's 4. And my God, he was just grinding away. And I mean, I was just observing that, thinking, wow, he's 4. This is really something.
Yes. A lot of these are being mistaken for so ADHD type of, behavioral problems that is now also on the increase, right? Like we're diagnosing more and more kids with ADHD. It's very highly associated with sleep disorder breathing as well. So I mean, I don't know what to say to this. I just think it's a problem of civilization, of society. We're noticing it more. The problem lies not in the diagnosis. I do think that it is a lifestyle disease nowadays. But the problem is how we're treating it, and whether we are sometimes over-servicing people just for a very mild benefit, and whether we know what each therapy does and how it benefits them. We can throw a multitude of therapies at them. We have no consensus in the literature what to do. It's very case-by-case basis right now. So it's a territory that people don't understand. There's a thirst for knowledge. Whenever you don't understand something, it's a law that you get attracted to knowing a bit more about it. And so there's a lot of sleep apnea courses and out there, but I'm just a bit concerned with what people know about different therapies and how they practice it, and whether they know the evidence behind it, and whether they're over-servicing. I certainly see it in my practice too. But I notice more in children. I believe in children you get a better effect. My 3 studies or 4 studies that I published out of that thesis was all about A, diagnosis, then the B part was treatment, and then it was a long-term follow-up in quality of their life. And I do believe a lot of kids that are coming through our doors have this, but whether 6 months from now they may not have it, I don't know. There's some studies that show if you leave these kids alone, some of them actually, it's seasonal. They're okay. There's a very famous study that was in the New England Journal of Medicine by Marcus, where they randomized 2 arms. One side, the children got adenotonsillectomy. The other side, children were just randomized to watchful waiting. And 6 months later, they found that 40% of the kids that were in the watchful waiting group actually normalized for a lot of parameters, not only just sleep study, but even behavior. And so the kind of question is this seasonal? Is there something else going on here where we're definitely overdiagnosing this?
So podcasters are young. Every email I get, it's a dentist under 30. So talk to the dentist. What if they want to know more about this? How do they learn more? I mean, because you're right. I do agree that a lot of sleep medicine study, what's really going on is they're trying to sell a machine, and they're just trying to get you to a course to sell a machine. And once you buy that machine, the goal is achieved. So and so that's what they're wondering. Do they need to buy a $5,000 machine to do this, or talk about where they should go on their journey if they're more curious about this?
Yeah, well, I think on the dentist role, really, they're definitely involved in screening. Okay, so as dentists, we're involved in screening. The American Academy of Pediatrics guidelines are that, and they should apply globally, that any kid that walks through your door should be screened for sleep apnea or snoring, because 80% of these kids are being missed by their general practitioners, the medical practitioners. So the simplest way to screen these children is just asking the parent, do you think they snore more than 3 times a week on a regular basis and it's not seasonal? That is the simplest question, and that's often the highest indicator of that whether they have snoring or sleep apnea. Then we've got to ascertain whether there's what spectrum they lie on. It can go from a mild spectrum of just seasonal snoring, even though it's chronic, to sleep apnea. Now, sleep apnea in children is very rare. Okay, they don't have the apneic episodes that adults have. So I'm going to speak specifically here of children, because that's what I'm an expert in. So it's pretty rare, and we need to consider that most of these kids are more in the snoring spectrum. Then we've got to work out if there's daily snorers, if they're just 1 or 2 times a week here and there. And the next thing you would do is basically take a screening cephalogram to just look at the airway patency. And I'm not a big fan of cone beam CTs to look at airways because a lot of times kids are upright, they're not sleeping, and the airway collapses when you're lying down. So I'm not a big fan of CBCT. Also, there's a lot of there are errors in that. So I don't like radiating children under 9. So just a cephalometric radiograph to quickly look at the patency of the airway. It's a screening tool, but it's a good tool. And simple is the best. If one of my studies, I'm not sure if I should put my PowerPoint on now to explain this better, but I did a sequence of 3 or 4 studies in this area. So this is what I give to a lot of general practitioners, and the amount of general dentists have told me, oh, this is great that we found an alternative viewpoint, what you're showing. I'm not telling them don't treat, but I'm telling them caution, and I'm telling them where not to treat. So I'm happy to put that on.
Let's do it. What an honor. By the way, I love your accent. I could listen to you for 40 days and 40 nights.
Thank you. It's actually a little bit sore right now from our winter, but I'll put this on now. I'll put my presentation on.
There we go.
Okay. So basically, this was what I was really interested in, right? Well, you really want to know when someone walks through your door, you want to know clinically relevant things. A, can you predict that they have sleep apnea or snoring? B, if they do, what are you going to do? Number 3, what is the evidence behind this all and the long-term effects? So, a kid like this walks through your door. Is she snoring? Is she not? She shows that little bit of retrognathic mandible, that class 2, bit of mouth breathing. You can see her lips are incompetent, narrowness in her palate, and we all start to go, oh, she's a snorer, she's a snorer. And we'll get back to that, whether she's not. And really, people start to think about morphology. They're thinking, okay, if someone's class 1, everything should be balanced. When they're class 2, the mandible's back and somehow may impinge on the airway. But when they're class 3, often the maxilla is retrognathic, and that might impinge on the airway too. In my experience, a lot of class 2s do not have snoring or sleep apnea, or it's usually soft tissue, adenoids or tonsils, which is not our domain. Yeah. Class 3, more likely to have airway issues due to morphology. And no one's looking at the transverse, because we all do cephalometrics. Everybody looks at the sagittal and vertical, but no transverse. So my study was to look at the effects of transverse. And the first one was a meta-analysis that got published in the American Journal. And this meta-analysis ended up with 9 studies as primary studies. And it did end up in the 25 hottest articles. I don't know what that term means, but yeah, it was pretty hot. Or it was number 5 on the 25 list. And what we did was we looked at these children that were snoring, whether just from the A and B angle or just their steps, can you tell they have sleep apnea or not? And what we found was really a very slight increase in the A and B angle. So either the maxilla was slightly forward or the mandible was slightly back, but it's a 1.54 degrees. And can you measure 1.5 degrees very easily by looking at a face?
No.
Yeah, no, it's very small, so it's not clinically relevant, Then we looked at, that's the A and B angle. And then we looked at the width of these children, and what we found that, yes, actually, there was a 15% reduction in the width at the back in the nasopharyngeal area, that red light, that red zone. And what that often means is, again, it could be soft tissue, the adenoids or tonsils impinging there. And they did have a slightly open bite tendency, so their mandibles are a bit lower and open. And not only me, I'm very glad this study came out by Westmead, who's an excellent orthodontist from Canada. And his study came out pretty much 3 months after mine, and he did exactly the same, and he found very similar results. So what that means is that really we cannot predict if someone has sleep apnea by just looking at them. It's unsupported. And there's another study that goes far back in 1996 that said the same thing in adults. Then we're looking, there's a lot of problems here. These kids are standing upright, not supine, and there's a lot of errors in x-rays, but it's still a good screening tool, okay? It has been validated by 2 major studies. So screen these children for the airway. It's not a bad tool. So my second study was prospective, where I said, okay, what's happening with these children? I really want to know. So a lot of kids that came to the orthodontic department, we did their surveys by the parents, and we categorized them as snorers or non-snorers. And at baseline, both groups were similar for a lot of variables that we tested. And what we found, though, the children that were snoring, nearly 70% of them actually had a narrow maxilla. And nobody looks at transverse. So this was the first study that started to talk about the transverse. And we also found that these kids had a 15% reduction in their quality of life, just according to the parents. They also had more, the snorers had more morning headaches, ADHD-type behaviors. But when we looked at their CEF, we found no difference. We just saw that the airway was slightly constricted. When we looked at their models, we found a difference. We found that they were quite narrow and about a 15% reduction. And so to answer your question, you know, people are putting up cases like that, look at her eyes, the venous pooling. I don't think we can just look at all of this and say, oh, someone's snoring and get alerted. We actually don't know, because it's a multifactorial disease, and this is what that jigsaw puzzle is. Malocclusion is just one part of this disease. There's so many other factors. So when it gets into treatment, there's all these different therapies out there. Currently, adenotonsillectomy is number one. In Australia, I don't know about the US, these kids are left, right, and center being sent to get their adenoids and tonsils out. Dental facial orthopedics is emerging, but it's down the bottom. And multi-therapies, personally, I think the order needs to reverse. Multi-therapy should be number one. But the problem is we don't know when we treat these children whether they recover and become healthy, because there's no long-term studies, whether they become healthy and there's a delay, or whether they always remain, have a deficit. And by deficit, we mean their neurocognitive functioning, the ADHD-type behaviors that are very highly linked to sleep apnea in children. And also, adenotonsillectomy is not that successful. You know, it's 25 to 75% success rate. Some things improve, some things decline. When we look at, this is the main study that I'm talking about. This is a fabulous study that every dentist out there should read. This was in the Reuters news when it came out. It was everywhere, okay? These guys looked at 464 children, like at an age where they're going to enter the dental practice. They had actual sleep apnea, so they weren't just snorers. They had moderate sleep apnea, actually. And what they found when they randomized them children to two groups, one watchful waiting and one was early intervention by removing their tonsils and adenoids, 45% of children in watchful waiting group normalized without treatment. So this is a big thing we need to take from this study. There's so many other results in the study, but that's what I take out of it. And sometimes I think watchful waiting is the best, best treatment can be tincture of time. I'm a little bit conservative. And we also need to know that all the Cochrane databases say the same thing. Strong evidence is lacking to support the use of adenotonsillectomy in children with confirmed OSA. Sorry, I'm just going to skip through here.
No, you don't have to skip. Just keep going. You got I'll stay up till midnight to hear this. I love the fact that you use a plane for the different planes. How cool is that?
Thank you. Thank you. So when we look at adenotonsillectomy, this is a very well done study in Scandinavia where they looked at 25 snorers and 24 controls. The snorers got surgery. Then they followed these kids up long term. This is a great study. What they found that the snorers had a little bit less maxillary width even after surgery. So what they were saying that if snoring persists, perhaps let's consider maxillary expansion. And I think that's the future. I think the multi-therapies is the future. So we always have to work within a multidisciplinary environment when we're treating these children or adults. I don't think this is a dentist-only domain. So when it comes to dental facial orthopedics, there's only three things that can help with the airway, and that's your maxillary expander, your mandibular advancement device, or your maxillary advancement device. And there's various designs of all these type of appliances. So what the mandibular advancement is doing, trying to get the mandible forwards in a class 2, and the maxillary advancement trying to bring the maxilla forwards. Now, there's some claims being made out there, and this is what I'm worried about, is all these studies coming out, rapid maxillary expansion alone can produce significant improvement in OSA. These were like 3 authors that say the same thing, but if you really go deep into their studies, seriously, they had no controls. Pirelli calls a study calls a study like a well-controlled study. There were no controls. And not every child responded to the expansion. When you look at the Villa study, he calls it a randomized controlled trial, but there were no controls there, and there were only 14 children, and none of them normalized, actually. When you look at some of the other studies, this is my study, actually, the third one, and what this showed is when we did do expansion, the quality of life improved, but it was just a 15% improvement. So we have to be careful what we say to these children and the parents of these children. So I wanted to look at why when we do expansion, the kids' breathing improves. And I did a very quick mini review of the literature, and I found that a lot of studies point to the same thing. You know, when they measured nasal resistance, when we open that maxilla, the nasal resistance decreases. What we don't know is how much, because all these children respond differently. There's, you can see why, for example, doing expansion can improve their nasal airway. But the problem here lies that children who already have obstruction and they've got enlarged tonsils and adenoids, they're not going to expand as well, and they're not going to show that the same response as a child who doesn't have these multifactorial issues with them. So what I'm trying to get at, let's not focus on the nose so much, because it only accounts for 50% of respiratory resistance. There's other areas that can cause respiratory resistance as well. There's a lot of devices out there for adults, all the studies are showing, look, there's a little bit of increase in this, but it's 15%, and we've got to work out for our child or adult, is this 15% going to bring this child relief? Do I need to get other therapies involved? The other problem with the children's treatment is relapse. How long are these children going to be in these appliances? You know, what is the long-term retention strategy? We really don't know these questions. What about the burnout of these children? Mandibular advancement in adults, again, you see the airway opening, but it's just a little bit more than before. Perhaps in an adult it can save lives, because in adults they have apneic episodes. They actually stop breathing. Children, not as likely. But if you're going to do adult sleep apnea treatment, altered morning bite is a reality, and it happens all the time. And these are really difficult cases to actually manage long term. So to young dentists getting out there, do not support doing adult sleep apnea treatment at all outside of a multidisciplinary environment. Let's look at maxillary advancement, right? There's a lot of there's actually one, and there's another one just come out. But what they're showing that the airway is increasing, yes, a little bit, but only 1.5 millimeter. We really can't even measure this. And then another one, Misidero in 2009, they're all saying the same thing. You know, when we are doing class 3, class 2 treatment, we're not seeing a significant increase in airway dimension in the short and long term, and they looked at up to 2 years. So we need to be aware of all this. Cochrane, which is our go-to for evidence-based medicine, says there's no sufficient evidence to state functional orthopedic appliances are effective in treatment of OSA in children. I'm not saying to disregard it. What I'm saying is to be aware of what the general evidence says. There's a new technique coming out started with Eric Liu in Taiwan, Ramek, where they're expanding the child 1 week, constricting, then expanding, constricting, and they believe by doing this they're getting better skeletal effects. I'm doing a study on this in Germany right now. We've got preliminary results. I think it makes a difference, but I think a very small difference. Again, very small differences. So what I want to caution everybody is not to become a serial expander. I show this slide of serial expansion. I was one of them. The amount of kids I expanded, then I see relapse. The ugly part is we don't have any consensus on management in the literature. We don't know how each therapy contributes, and we don't know the long-term efficacy of any of these therapies, actually. And we need to be aware and inform the parents about this. Myofunctional therapy is coming up now where everyone's talking about myofunctional. There's literally very weak evidence for it. Therapies are going to be the future, I think, but genetics is just emerging. Why one child responds better than another child? Perhaps there's a genetic role in there, and they're really starting to find genes that are more prevalent in a chronic sleep apnea child than in just a chronic simple snoring child. And so these bring up questions that we really don't know much about this area. So when there's gurus out there talking about, sleep apnea, got to deal with this, got to treat this, I just think perhaps they don't look into the studies deeply, because when I really look deep into these papers, I actually think a lot of them are flawed. So what? I think the take-home message for the general dentists out there are, please screen the children. The guidelines say to screen them, so simply by asking a question, do you snore more than 3 nights a week on a regular basis? If a parent is concerned about their child, most likely the child has some sort of airway disorder. The diagnosis has to be managed by a sleep unit. You are not to diagnose. You can recommend a maxillary expander only if you think the child has a narrow maxilla and you suspect that they might have an airway breathing issue. However, the parents need to be informed that we don't know the long-term success of the therapy in a child. And we also need to be aware that children that have obstruction, whether it's by tonsils or adenoids, and you're going to expand them, they're going to show poorer response to the expansion. So the fundamental questions we need to ask ourselves before launching into treatment is, can we really change skeletal dimension of the maxilla and mandible in the long term? I think the evidence on the long term here is actually, it's amazing. We think we make a big difference, but when you look at these people 10 years down the track, everybody who's a class 2 goes back to a slight class 2. So we make a slight difference, not a big difference. So sometimes I think we subject these children to a disservice by prolonged and unnecessary treatment. And we need to answer these questions. And sometimes, according to this Reuters study that I was talking about, the fabulous study, sometimes just waiting 6 months is not a bad idea. If it's a very mild case and you're unsure, just waiting 6 months is not going to do you any harm. So that brings me to the end of my presentation. There's some stuff from Germany, but I think I will just cancel the slideshow and get back.
So, Vandana, you were also going to talk about a miniscrew-assisted class 3 treatment.
Yes.
Is that another presentation, or was that the end of your presentation?
Talk about it. Let's not make things heavy. I want to talk about it.
Oh, okay. Well, I want to go on a couple other things. When adults have sleep apnea, there's other things you can look for, obesity, heavy neck, things like that. Is that the same with children? You're asking if they snore 3 times a week. Is it more common in obese kids, or kids that grind their teeth at night, or bruxism, or?
In children, okay, so there's a lot of conflicting evidence. In children, they say mostly obesity is not a factor. The biggest reason for children is glandular enlargement of tonsils and adenoids, which regresses. We know by 10, 11, it regresses. The biggest factor in adults is obesity. And of course, in that way, your treatment methodologies or treatment regimes are different for both. In children also, as I said, they don't have those apneic episodes as much. And they often have more nasal issues. So sometimes just doing some nasal steroids can be enough. So we need to go very simply with them. There's conflicting evidence on grinding. So there's, people go, oh, look at this, look at that. These are all associations. It doesn't mean a child has sleep apnea if he's grinding, or he has to be treated just because he's grinding a lot at night. Transitional grinding can occur. I mean, if you really want to talk about that, my study didn't find that these kids were grinding at night. And I know I had a sample of only 80 children, but we did find that the parents were complaining of ADHD type behaviors, morning headaches, dry mouth, that have been shown by other studies. We asked the question of bedwetting as well. We didn't find it. Some studies have found it, some haven't. So I suppose, again, you kind of, when you try and understand this, you're thinking it's multifactorial. We really don't know what's going on here. Some kids are responding differently to this disease and the treatment.
I think bedwetting's related to drinking. That's the only time I ever noticed it. All right. And yeah, I'm doing my own sleep apnea study. I had a sleep apnea test on myself, and he said I was one of the best sleepers ever. And then I read that it was linked to obesity, so I've been gaining weight ever since that test. I'm doing a study to see if I can get so fat that I could induce sleep apnea. Back to those tonsils and adenoids. I mean, do you think tonsils and adenoids are kind of like the appendix and the gallbladder and the wisdom teeth? You don't really need them, or are you trying to fight to save them because it's part of the immune system in the mouth? What are your thoughts on?
I think that any surgery has a risk and morbidity, and I am a conservative practitioner. I looked at my evidence, and if it was my child, I wouldn't subject them to that all the time. It's not, but it's again being overused, and it's hard to say. I think the most important thing is you have to choose who you listen to. There's so many gurus out there. There's so many gurus from other disciplines. People put up papers on Facebook all the time. Look at this new research come out. Look at that. And then I read the paper and I say, hey, this was only done just 6 months follow-up. Secondly, this is a Caucasian population. This is not related to, you need to address these things. You need to understand when you read something that it's just giving you an approximation of things. It's not the be-all and end-all. It's very sad that some gurus are using these papers without really going deeply into them and showing these younger dentists how every child needs treatment. And, everybody, we need to all be sleep dentists now. And so I'm sorry I give a different view, actually. I know I'm not giving the norm. And it's truly what I believe, because I see the response in my children. I'm very alert about the airway. When I do expansion, some kids improve, some don't, and I know that. And also, I don't know in 5 years whether it's going to come back.
So on the research, you were the 25 hottest articles. So can we call this podcast that Dr. Vandana is one of the top 25 hottest dentists in the world? Since we have research to back this up.
Oh, go ahead, no problem. A title's a title, right? You need to. It's just the title. You need to open the book and read it to really know whether it is hot.
So I was born in '62, and one of the first times I had a sore throat, they took out my tonsils and adenoids, and then of course when you turn 17, they take out your wisdom teeth. But I was wondering, do people think like me missing my tonsils and adenoids? Is there any research that was not a good idea? I mean, did they have a purpose and a function where research would studies say that Howard would be better off with them? I mean, not just the surgical risk and complications taken about, but do they serve a purpose?
Yes, they do. There is some evidence coming out now, long-term studies showing that, people who didn't have them removed have better immunity. These are indirect studies. Again, I am an orthodontist. Pediatric specialists would be the best people to answer this. I stay on top of this area, but I probably would not know as deep as they would know. But from what I understand from all my conversations with pediatric specialists, that there is some evidence coming out that they are required for immunity. There's a purpose. There's a purpose for every organ, I think.
And going around the world, you see differences in diagnosing and treatment plannings, and it seems like America has 5,000 oral surgeons, and for the most part, they remove wisdom teeth because they exist. But when you go to Germany, you see oral surgeons have kind of a long litmus test on whether these wisdom teeth should go or not. You're between the United States, Germany, and Australia. That's a huge triangle. Which side of that triangle are you on down under?
I think I'm more into watchful waiting, triangle for a few months. Let's do it again. I'm gung ho for surgery if it's required. Um, I'd say I like to not put people through unnecessary surgery if I don't think, I let them make the decision. I show them, I tell them about, there is some chance of what can happen with pathologies, leaving them behind. There is a chance, let's remove them early. I let them decide. It's their lifestyle, it's their choice. You'd be surprised that even though I would believe they need their wisdom teeth out, they will turn around and say, no, I don't feel, I don't want to. Can we just watch? And then we manage it that way, So I try and, I mean, we sometimes get so excited about treatments and even brackets, right? Everyone bracket is 1 degree controlling this torque better and my wires are better than yours. And I really feel it's what the patient feels at the end of the day. What do they perceive? Their perceptions are important. And we don't have a lot of studies about that. How we influence the decision, what we do, whether after having surgery, how they feel, the morbidity. I just think we need to start becoming more patient-focused than treatment-focused.
I agree, and it's refreshing to hear that from an orthodontist because the United States has 19,022 towns. Most of the dental schools are funded by state tax dollars. So when a kid comes out and says, oh, I paid this much to go to school, yeah, well, your state paid probably another 50%. And then the orthodontists and the 9 specialists all go to the big major cities of over 50,000. And there's all these small towns of 5,000 that just have a general dentist. And when that general dentist was in school, if she wanted help on a root canal, the endodontist would help her. If she wanted help treating a kid, a pediatric dentist would help her. If she pulled into the oral surgeon right there. But when it comes to ortho, they get zero help. They graduate from school with zero orthodontic training, and the next thing you know, they're in a town of 3,000, and mom's asking her about her bite, this, that. And there's just been, the orthodontists just do not transfer information to general dentists. It's almost like, if the patient is first, then we, as a profession, all the specialists should be helping everybody so that we put the customer first. In fact, in fact, it is almost impossible for me on Dentaltown. We have 430 courses on Dentaltown. They've been viewed over 600,000 times, and it would be easier for me to go to Mars tomorrow than to get an orthodontist to build me online CE courses. I mean, they just won't do it. I wonder if there's any way you would do it.
No problem.
Really? Because if you do it, I mean, orthodontists, they tell me off the record that if they are teaching general dentists, they'll be blackballed by their peers.
Yes, I agree with that. I totally agree with that.
So you do agree with that?
I agree with that.
And that from...
It's generalization. I would say it's not, the younger generation of orthodontists, I think, understand. They understand what has happened in the last 10, 15 years. We're not helping our peers. We're not transferring, like you said, or sharing our knowledge. If an endodontist shares his knowledge, what does the dentist learn? I will tell you what they learn. They learn their limits. They learn what they can do better. They learn what they can do not so good and needs to be referred. And I truly believe if orthodontists started something like this is the effect that's going to happen. General dentists are going to learn to do simple things a lot better, a lot more efficient and quicker. And the complex stuff, they will learn to pick up quicker than any other dentist. Hey, this needs to be referred. So I truly believe knowledge is power. There's a lot of politics, as you know. There's a lot of this. One of the other things I suffer is I'm a woman in dentistry. It's not easy. Yeah, I get ignored very easily, but I keep standing and I make sure I get noticed. And I really believe that by doing an online course like that, it's going to benefit patient at the end of the day. These patients put trust in their dentists. The dentists believe they can do a better treatment, so they go ahead. Unfortunately, it's it's not happening that way in reality. Yeah, and when problems happen, no one's helping these dentists. I also find that the ortho gurus out there doing all the orthodontic courses are, I'm not going to name names, but as a general rule, I think they're not helping, or they're charging more money to help these dentists. It's all become a game of money. Yeah, this is all money driven. So what I want to do is create stuff for non-profit, because one of the challenges I have in my profession that they're pointing fingers at me saying, oh, she's doing this for money. I'm inviting a lot of orthodontists around the world saying, come lecture with me. Let's start this study club. Let's do this. And let's do this for non-profit. Money doesn't drive me. What drives me is patient care and looking after that patient that no one cares about.
You are a saint. All right, I'm going to start calling you Mother Teresa of orthodontics.
I'll stay single. I don't want to be single.
So let me. I try to ask a lot of questions. If my homies out there listening, why ask the same question over and over? I just ask questions based on what they're emailing me. And you can email me, howard@dentaltown.com. What if someone wants to email you? Can they email you?
For sure. I have become very busy in my own private practice with BOSS, with all my research endeavors. I like to publish 1 or 2 papers a year. They may be a lag, but for sure I'm very available.
What are your websites and email? What website would you rather go to? Because you got a couple.
Yes, I would say the CCC Smiles would be my best one, my clinical orthodontic website. A third one with just my name will be coming up soon, and they'll be able to contact me easier. I would say info@cccSmiles.com.au.
Right on. And so one of the questions they're always asking me is that they come out of school and they're just bombarded with things they should learn. And one of them is the occlusion camps. In America, in the United States, it seems like there's a neuromuscular camp of occlusion, which is like LVI, Bill Dickerson. And then there's more of a CR type of occlusion, Pankey, Dawson, Coy, Spear. And they can't afford to take every institute because they're extremely expensive. Is there really, what occlusion camp? Do you break it up into CR, neuromuscular, or not really?
No, I don't. I have attended some of those courses on LVI dentistry, so I'm aware of their philosophy. However, I don't follow that camp at all. I just follow simple rules on occlusion, getting your canine guidance, getting functional occlusion. I have done a big study or a big literature review on functional occlusion. There's such a variety, where people we think should have TMD don't have TMD. And I really think not everybody has to be treated to the same. These are all treatment philosophies being sold to just constantly generate more money in business. And I'm not naming names here. I'm sure they help. So every knowledge is good knowledge. Go learn these things, but don't follow them religiously. I think you have to then do your own self-study. And this is what we're lacking. A lot of young dentists are out there doing all these courses thinking they're going to learn so much and it's going to be more profitable for their business. What they forget is that self-study and self-discipline and is really the key here. And, I don't stop reading. I read all the time. And, there must be some prosthodontists in the area they could go to, strike some conversations about this and, slowly learn. That's how I learn. When I was a dentist, I started approaching my local orthodontist. Now, I was very lucky that he was very open to me approaching him, and I asked lots of questions, and over time, I learned the complexities of it. But if he was not open, I think it would have been very difficult for me. I probably would not have become an orthodontist. I would have been one of those angry people, orthodontists are like that. So it's a generalization. I would just say, just do not follow one school. I think our evidence is so limited. Human variation is so amazing. And no philosophy can fit one person. as a general rule. So when I look into these kind of systems, I always go, okay, where do my thoughts lie? What is the evidence here? What is the evidence there? What do I think is more balanced? And then how can I apply this to this patient? But I'm going to apply a second principle to the other patient. So it's very case-based diagnosis and specifics that I believe in. So it's hard for me to answer when you say what school, because I don't belong anywhere. I belong here, you know.
When I say I follow someone religiously, that means I don't believe a word they say. So another thing they're hearing is there's a lot of sleep gurus out there that say that if you make a night guard for someone because they grind their teeth, without that you have to get them a sleep apnea study, and that it's malpractice to make someone a night guard to protect them from grinding their teeth without a sleep study.
I don't agree with that. I do not agree with that. Is this particularly to treat sleep apnea?
Well, they're just some of the sleep apnea gurus say that grinding is so associated with sleep apnea that you're causing malpractice, and this guy may die in his sleep by an apneic episode, and that you cannot make someone a night guard unless you rule out with a sleep study that they don't have sleep apnea.
I think what they don't understand is how hard it is to get that sleep study. People don't have money privately. How the waiting list in public, they're just over treating. I think here there is a link, but it's controversial. I hear this all the time. They're grinding. This is it. This is sleep apnea. You know, it's controversial. If you go deep into those studies, they're just association studies. It's not relevant to everybody. So based on that, no, they don't. But if you do believe they have sleep apnea, definitely, yes, I think a sleep study is warranted to get a baseline. And I don't think they should be treatment planning or providing a night guard without consultation with a sleep apnea specialist or a ENT surgeon. You know, I just think you're just taking on too much. This is a multidisciplinary problem. This is not one thing. It's not just occlusion.
You know, I think the smartest people are moderates, and the extremists, you know, all black, all white, up, down, left, right, are just batshit crazy. And when I was little and got out of school 30 years ago, true, a lot of orthodontists, every single patient was a 4 bicuspid extraction. I mean, it was just out of the door. And then the pendulum swung. There's all these people still going around today that just preach against it, and they basically saying if any orthodontist does 4 bicuspid extraction, you know, they're just horrible people. And the truth is somewhere in the middle. Help my young townies. What's your view on bicuspid extraction?
My view. So my view is where it's needed, I think it works beautifully well. I don't think it causes the dishing in of face, because every study after some claims were made in the 1990s or 80s shows that there's no change to the transverse. There's a fabulous study, you know, then you go, okay, let's not look at this. Let's look at the face, right? A fabulous study out of Melbourne came out, actually, and this study won a lot of awards, where this orthodontist student looked at buccal corridors, pre and post extraction. And who were judging these corridors were not just lay people, it was orthodontists and dentists. What they found, whether they did extraction or non-extraction, the smile aesthetics did not change in this. And she did quite a good number of patients. Fabulous study. She did I think 2 papers, both published in the American Journal. You know, we know that the transverse width doesn't change. So if you diagnose things right and they have 10, 14 millimeters of crowding, where are you going to gain the space? It's just logical to remove premolars. Sometimes, yes, you have to remove molars. You have to know about anchorage and biomechanical principles to control your incisors. If you control your incisor angulation well, there's no dishing. Most of that space is going to resolve crowding. And there's so much evidence for this. And, there's still people that say, save the 4x4 or, preach against this. There's so many dentists who constantly email me, even in Australia, hey, are you a non-extraction orthodontist? Because, all the other orthodontists in the area are extracting bicuspids, and we want to find someone non-extraction. And my response to that is, I do what's right for the patient and based on evidence. And, it's hard for me to say where I believe. I believe if it's done in the right case, it works beautifully. If it's done in the wrong case and you don't diagnose it right and you overestimate crowding, that one of the problems with general dentists estimating crowding, they actually don't know how to estimate crowding because they haven't done that much. They don't see how they're going to change the angle of the incisors. I know that because I talk to my general dentists in my area all the time, and they're coming and talking to me, showing me cases. And I realized very quickly that they're not a good, they don't diagnose crowding very well. And if you were to extract on that, not knowing how much actual crowding there is and what you're going to do with your incisors, you're going to make blunders. So perhaps they take the safe route of just not extracting.
And, well, in 2016, dental students still tell me, and I witnessed it with my own eyes, that when they ask the orthodontist in their dental school a question, they say, well, you know what? If you really need to know that, you need to go to orthodontic school. And I just couldn't imagine somebody saying that from the endo department, the oral surgery department, the pediatric dentistry department, or, the prosthodontist department. I mean, so when the dentist can't measure crowding, explain how they got out of dental school 4 years and $350,000 in debt, and they can't even measure crowding.
Yes.
That's not the base. So that leads me to my, by the way, that study you said that was done in Melbourne, was that on kangaroos or humans?
Humans.
It was humans. Okay, I was just making sure you didn't switch gears to kangaroos on us.
Because we do like to do our research on kangaroos. So we actually like to eat them as well.
So back to the kids though. What would you say if they're thinking about wanting to take an orthodontic course, they want to learn, say, clear aligners and Invisalign or something, and the instructor is 100% against non-extraction and badmouths it all day long? Would you say that's a red flag that you're dealing with an extremist and to run?
Yes, red flag. Don't follow blindly. People who make it look simple, everything simple, and give you a cookbook approach, I always question it. They're trying to sell something, especially when they're selling their own products behind it. I'm generalizing this. I'm not saying everyone is like that, but yeah, I would question that. And, I was one of those naive dentists. I really was. I graduated from Sydney, 2001, hungry for orthodontic knowledge because I didn't have any. I had good knowledge of endodontics, prosthodontics, periodontics. I did not have good knowledge of orthodontics, and I loved children and teens, and I knew that's what I wanted to do. So where would I go? I went to all the courses I could attend that were out there, and I learned very quickly that some were very extreme, some were balanced, and by quickly, it still took me 3 to 4 years to figure out what was going wrong, but everything was made so easy. It was like, just do this, just put this bracket, use my wire, use my technique. It was so easy that when I started to do it, I realized, what am I doing? It's not easy to finish a case. There was no support for diagnosis. There was no support for ongoing treatment. So with BOSS, my second company I've started, it's not about training dentists to become orthodontists. It's about providing support to do simple cases really well, to get a multidisciplinary environment. There's a perio involved, there's a pros involved, for all of us sit down and diagnose things together. How beneficial would it be for these dentist patients? All I see is the patients at the end of the line. They are getting great informed consent, all the risk management tips. This is complex for you, this is simple for you. I just see it's a win-win. And it's sad that not many would follow that philosophy. And I wouldn't generalize. I think some of the younger orthodontists have approached me and want to start lecturing with me and develop content, which I'm very glad for. But there's also some reputation about me, which is not very nice, because I'm very evidence-based and I give up a lot of my time, money, and energy for the profession to make it a better profession. And that includes all my self-funded research that I continue to do.
Well, how can we get some of that on Dental Town? There's 217,000 dentists, and they can take every number of courses on root canals, fillings, crowns, so they're blue in the face, and then orthodontics is a big donut.
Yeah, I'm happy to create content because I'm already in the middle of it, so I'm happy to share that content.
And I'll do anything to help you in your mission, and it'll give me an extra excuse to come see my brother.
Yes.
I've gotten every time. Did I take you? Who did I take? I took Greg and Zach. The oldest boy's married. Ryan didn't go. Can I tell her why he didn't go? He had a hot girlfriend that week. I'm like, are you kidding me? You're gonna stay here? But he fell in love for a couple of weeks, and it coincided the trip to Australia. So that must have been one hot girl. So a big question is they're hearing is that they should learn Invisalign. I do have to admit that I'm very proud of Invisalign. The fact that since I got out of dental school in '87 to 2016, that Crest and Colgate were the two big brands when I got out of school, and Listerine. And there was not a single orthodontic brand in the world. And now anybody you meet in America, anybody you sit next to on an airplane has heard of Invisalign. I mean, they have made an amazing brand. The marketing department in Invisalign. But anyway, so the problem with the young dentists is Americans are coming in and they all already know that you don't have to get braces. You can get these Invisalign and so what would you say to a young 30-year-old dentist if she's thinking I would learn Invisalign? What would you tell her?
I would say, okay, I am actually a little bit pissed off with Invisalign as a company. Love the company. I think they have
I love it. I love it when my guests piss off my advertisers. So just lay it on thick.
Yeah. I seriously, I think this is a model to follow. What they have done is incredible. When it comes to patient management, they come and support your clinical team. They're pretty much doing what BOSS does. They help you with branding. They help you with team support. They help you, get accredited and get started, and they don't stop until you're really comfortable with it. Great, right? The problem is they don't have a very good clinical advisory system that you can access very easily in your local area where an orthodontist can help you design your treatment plan and your ClinCheck. That's where everything is failing. Some of these dentists go to these 3-day accreditation courses by Invisalign, not much support afterwards, and their nurses are approving ClinChecks, and I see these cases because I get some dentist sending me a case, hey, can you help me here? And I was like, this is not an orthodontic case. This is a perio case to begin with. And those little basic things, they cannot teach, right? So my advice is go do Invisalign accreditation, fabulous. I think Invisalign will change, it's already changed the world. My clinical practice, 95% is Invisalign. I very rarely do braces.
95%?
95% Invisalign.
And what percent is for bicuspid extraction?
I would say about 20%.
And 20, so you're doing even your so 1 in 5 is for bicuspid, and you're even doing those with Invisalign?
Yes. I'm doing extractions with Invisalign. I am now pushing the boundary and starting to do impacted canines. For my teens, there's no question. I've established a niche in Sydney where teens find me through Instagram and Facebook, and they only want Invisalign. I'm getting fabulous results. Invisalign is something we don't have a lot of research on. We have a little bit, but not a lot. And it's a very clinician-specific tool. You've got to learn from your failures here. And I've done so much Invisalign now that I kind of know what to do, what not to do. It's not taught anywhere. So to my request to the dentist is somehow find an Invisalign guru who is open to helping you. I know there are some people who do it online. They do like Skype sessions. There's some orthodontists in Canada. I think there's one in Australia as well, where you can access your first 5 or 10 cases you need to show to an orthodontist to get started. It's a very different mechanics. It's not like braces again. It's very different. I love it. My patients love it. I love it. My teens love it. I get great results in the same amount of time. It's going to change the world. Aligner therapy is In 5 years, we're not going to be putting brackets on. I see brackets now as barbaric. And the oral hygiene decrease, the white spot lesion. 95% of patients with brackets show white spot lesions somewhere. And, when I take all these in consideration, I love Invisalign. I use it because I see the oral hygiene improvement. But in saying that, I know the limitations of it, and I will tell them always that I might need braces at the end. But I try and reduce their time in fixed appliances. So to the dentists out there, you have to find a mentor, which is the hardest part. Getting Invisalign accredited, getting started is great, but you have to understand the software, get as much support from the company, but eventually a really good Invisalign operator is your key. And you're right there, Howard, there's not too many who will open the door and show you their way. Even orthodontists with orthodontists are very secretive. Yeah, you're a competitor. Everyone is a competitor. So it's not very easy to get that. It's very sad that that's how we think. We don't care about that patient at the end of the line, but that's reality. That's going to be the hardest part.
Yeah, I agree. So some old guys like me think that if you do Invisalign, you do it on a beautiful woman, she's motivated because she'll do anything to be pretty. But then you got boys who, they wear the same shirt 3 days in a row. Do you have do you have compliance problems with young boys, especially the boy whose mother is pushing him into ortho because the mother wants straight teeth? And then if you put brackets on, you're in control. But by giving a boy something he can take out of his mouth, do you have compliance issues with young boys?
I haven't noticed. The amount of teens I'm doing is increasing every day. I have not noticed non-compliance. In fact, I have problems with adults who just say that they're going to do it and they're so motivated. They're the ones who after 6 months, is it going to finish? Yeah, they're the ones who start to show me problems. The teens absolutely love it. They go to their school. They're swimming with it. They see their peers have won braces. Nowadays, everyone's becoming more self-conscious. We need to talk about this. At year 12, 13, the psychology of a teen is starting to get attracted to the opposite sex. And it creates a lot of self-esteem issues in them. And when you remove a lot of those, I see the confidence in my teens, and just having that opportunity that wasn't available 5 or 10 years ago, they appreciate it. And it's also how you say it. Now, with fixed appliances, there's still compliance. They still have to brush 3 or 4 times a day. They still have to control their diet. So to me, both appliances require compliance and commitment. I just find that I don't have a compliance issue either way. It's because I continuously reinforce it, and I get my staff to reinforce it. And we use positive psychology to motivate them all the time.
Yeah, I do. That is amazing. So, but you're also you've done a lot of work on miniscrew-assisted Class 3 treatment. What are your thoughts on that? I mean, because Class 3 basically you're just genetically born that way, right? I mean, you're just born with a larger mandible.
That's a minority, but a lot of them are maxillary retrognathic. Or they have a combination. So we think there's more maxillary retrognathia than actually true mandibular prognathism. It's relative, and the earlier you start, the better. So with my traveling scholarship, I was very lucky to visit Lorenzo Franchi in Florence and University of Düsseldorf in Germany. And what I found was that they are putting mini screws. Germany is unique. They actually do all their expansion and Class 3 maxillary protraction treatment all using mini screws. Why? Because they believe, I think, they're getting a better skeletal effect and reduction of compliance, or not wearing the headgear. They use intraoral. They put a little mental plate down here, 2 screws, expander, and the kids are wearing rubber bands. It's fairly invisible as well. They're getting really good results. So is the Florence department. I published a paper in the Australian Orthodontic Journal showing that when you use miniscrew, there was a little better protraction, and also the vertical control is really good. So these kids don't open up. The biggest problem in orthodontics, which dentists don't understand, the moment you put braces on, the bite opens up. And if you don't know what you're doing, that can be very hard to actually finish. So with these kids, with miniscrew, you're getting forces closer to the center of resistance of the maxilla, so more skeletal change. What I really wanted to look at was whether this is worth it than conventional. So my second studies looked at conventional treatment, and it's in preliminary stages. We've just analyzed the data. We're going to be writing this up. But we found that when you compare to conventional face mask and a 4-banded expander, and you look at a miniscrew expander plus a face mask or an intraoral mental plate, we found that definitely the kids' maxillas came forward a lot more, and there was better vertical control. But when we say a lot more, we say about between 1 to 2 millimeter. Perhaps for some children, that's very important. Perhaps for some children, that's very small change. It's relative. So yes, there's a lot of exciting area. It's a very new area. And I also am looking at this ultramic protocol, which is like alternating. They're expanding, then they're constricting, expanding, constricting, and they believe they get better skeletal effects. So I'm looking at all these protocols. I think sometimes you've got to weigh up the balance. I'm not convinced that they're for everyone. I believe in certain severe cases I would use miniscrew-assisted expansion, but I think in mild to moderate we could get away with conventional. So that's my gist of what I found in Germany, and the next couple of papers will be coming out from that research.
So it's pretty tough patient compliance to get them to wear a headgear, isn't it?
Yes, very tough.
Yeah.
Very tough. So they're trying to reduce that compliance by using a little mental plate and just having intraoral elastics. And Hugo de Klerk has shown that as well. He started this whole technique where he puts 4 bone plates, and the kids, these are young kids, and he's showing fantastic results, and he believes he's getting a better skeletal change. But it's all relative, yeah. So I have had cases that have come into my practice where the dentist has said they're going to do this miniscrew expansion and all of that in a very mild class 3 case, and I often question that. And I said, I think this is very mild. You don't need all this. But, someone moderate to severe, of course, it's an option for them. But again, it's a patient's choice. Is this your cat?
Yeah, she gets very mad when I'm not staring at Mimimi and I'm staring at you. She can't figure it out. So look at her. She faces the screen. I think she just can't. And she lays right on my notes. Mimimi is one of those cats who graciously allows me to live with her. But anyway, so let's switch to the business side. What works in the business of orthodontics? Do you like to do marketing, advertising? Is it hours? How's the business of orthodontics in Sydney, Australia?
Okay, highly competitive. Highly, just like in America. We have everybody doing orthodontics. Everybody. Invisalign, is doing orthodontics. And I've heard there's this DIY orthodontics starting in the US where you just send a photo and you're sending a mold and the aligners just get shipped to your house, removing the need for a doctor. It's really, I think we're heading that way. So it's very competitive. It's been very challenging, but I'm very proud. 12 months ago, I established my practice. And I went for it. I went for in every way. I've done every marketing you think of, publishing, advertorials. We have done Sydney-wide radio campaigns. We have done digital marketing is our strongest point. But what I think at the end of the day, if you start your own practice, is ignore your competition because they put you down. And, much like anywhere else, believe what you do is the best thing for the patient. Do the right thing by the patient. Your practice will flourish. And that's always the principle I've been led by. And, we've got amazing reviews on Google for our practice. I maintain a one-on-one contact with every patient. I know them inside out. I get to know them, their lifestyle. Why are they making this choice? Why now? I get deep into it. I'm not just straightening their teeth. I'm really helping them. And I like that attitude, and I think it has done me really well in my 1 year of opening my practice. And we've just opened a second location, and we are growing exponentially. And I have my staff and team to thank for, but also all the marketing specialists I went to. I took a big risk. And sometimes I think you just got to take that risk. I took a lot of risks. And what I didn't change was customer service. That has never, ever fallen down in my practice. We go out of our way to make sure from the time that phone call comes that these patients are engaged in every way. They become part of our family from day one. And we don't stop impressing them. And that's the philosophy that has made me grow so quickly now. And it's only been 1 year, so we're still growing. I'm trialing different things. It'll be a nice presentation one day I'm starting to study a bit of psychology of consumers, and I'm starting to get into that, and I'll have some stats to show what worked for me when I changed certain strategies. And it'll be a nice presentation to do for some young dentists, because I made a lot of big mistakes as well, very big mistakes, and expensive mistakes. But I'm very happy where I am, because all the time I was centered by the fact that I have to give my patient the best care for them and the best service. I had to excel in service. So, yeah.
Wow, you're amazing. You're only been open a year, and you're going to a second location.
Yes, and a third one on the way in a few months.
Holy moly.
Yeah.
You might be the #1 unicorn in dentistry, in orthodontics and dentistry.
No.
was your nickname Unicorn?
No. It was actually Momo, which is like a steamed dumpling.
So do modern orthodontists like yourself, what % of your patients come directly from B2C, consumer to business, straight to you, versus come to you via B2B, a dentist referral? What's the breakdown on B2B versus B2C?
So for most established practices, it's about 80% of the referrals are coming from dentists. For me, 1 year out, starting out all on my own from scratch, it was 80% were consumers just walking through my door without a dentist referral. And so I heavily target consumers. I actually think going forwards, it's no surprise we're going to see less and less dentist referrals. It's no surprise there. And I know that, and I'm very aware of it. So my strategy for marketing is direct to consumer, getting their testimonials online. You have no idea of the power of a Google review, Facebook review. We actively ask for, if they like the service, would you like to put that down somewhere? We would love that. And, in 1 year, we've collected 30 reviews just from asking, and patients just go out of their way to write us reviews. Sorry, to answer your question, can you just remind me of the question?
B2B versus B2C referrals.
Yeah, it's going to be more consumers direct to you as a specialist. I think so. Online presence is super important. Having a great website. If you go to ccccsmiles.com.au, you will see that content on our website. Very few websites come close to ours in Sydney, and all that content's written by me and my team. And we don't stop with that. Yeah, building content on your website is key, but talking to your patient and conversing with them in that content is more important than copying and pasting technical lingo. So all that content is word by word written by us as we're talking to the patient. We found YouTube has worked well for us. We do a lot of YouTube videos all day long. I like to be on camera. It's me. Social media has worked really well for us. Radio campaigns have worked well for us. print, when we do a print ad, we found that when we did branding ads, it didn't work for us. But when we changed our strategy to write articles about thumb sucking, snoring, we have patients coming from all over Sydney, bringing these little advertorials that I write and saying, I just wouldn't even go anywhere else because you wrote this, and it's relevant to my child. So I found the advertorials have a huge impact, and we continue to change our strategy month by month. You know, I monitor everything. My team's very involved. They grow my business, so I'm very lucky.
You are an amazing, amazing, amazing person. And you are so busy. I can't believe you're going to have time to put some online CE course on Dental Town.
Oh, I definitely can. There's no problem. And I've got some content ready already to get some basics started out of BOSS. So it'll be stuff I'm developing for BOSS that I can actually transform for you. For example, that Dropbox folder I shared with you has got a couple of video lectures recorded already. More are going to come this week. In August, we'll have another 4 or 5 lectures recorded. And they'll be the basics, you know, and we're going to talk a bit more into journal articles as well, because I want my dentists to be smart. I don't want them to not know what root resorption is. What's the risk here? They're smart, and I really believe I want to research these dentists who do BOSS, and in 5 years, I think we can show that the patient outcome will be better if they get the mentorship of an orthodontist. I really believe the change is coming. It's going to be slow. It's going to take time. I'm aware of that. I wish time wasn't a factor, but it will be. And in 5 years to come, hopefully, some patients are benefited from this all.
You are so damn amazing. I'm gonna speed up my trip to go visit my brother just to see you in action. That's you're just an amazing person. You really, really are. And it's a
and I'm very excited. I'm very excited about my new book. It's called Love is All You Need and a Good Orthodontist. And we're writing this book to connect with the patient on what goes behind the scene. This is not just straight teeth. We talk about the psychology of a smile, the benefits that we see that we never quantify. You know, you see a woman after straightening a teeth just beaming, and you can't quantify this. And, you know, it's just things like that we bring to their attention. What goes behind the diagnosis process? How do you keep the cost down of treatment? How, you know, so we're talking in simple language here. So I'm very excited about this book. And eventually I want to do a cookbook for people with braces.
Man, you are a motivated person. You have more energy than than I can think of. That is amazing.
Thank you.
Well, when you come out with your book, call me back, and I'll help you push it out on social media or Dental Town or Ortho Town or whatever. Anything I can do to help, you just always let me know.